So if you walk into an intensive care unit today and you look at a patient's chart, the medical words flashing on those monitors to describe their body are, well, in a lot of cases, they're the exact same words a Roman general would use to order dinner.
Right, which is just wild to think about.
It is. We have this expectation that medical language is this pristine, flawlessly calibrated system, engineered in some sterile lab. But when you actually dig into it, it's this bizarre bilingual battlefield.
Yeah, it genuinely is. I mean, medicine didn't just invent a new language from scratch to describe human anatomy. It absorbed vocabulary wholesale from two different classical empires.
Usually the exact same time.
Exactly, which created a linguistic landscape that is, well, incredibly dense and honestly, surprisingly messy.
Which is exactly our mission for this deep dive. I'm your host, and today we are decoding the gateway to the digestive tract, so the mouth and the tongue.
And I'm thrilled to be here for this one.
We're so glad to have you. So to unlock this anatomy, we're focusing on 3 root words that if you're listening to this, you are probably surrounded by without even realizing it. And those are oro, stomato, and glosso.
Yeah, and if you're out there wondering why you should care about ancient linguistics when modern medicine has, fMRI machines and gene editing, it's because these specific roots are high-stakes tools.
They're used constantly, right?
Oh, every single day they dictate how prescriptions are filled, how surgical orders are communicated. I mean, they are the operating code of the hospital.
Okay, so to understand that operating code, we really have to understand the 2 ancient empires that forged it. Let's start with the Greek foundation. We've got stomato from the Greek word stoma, meaning mouth,
Right.
and glosso from glossa, meaning tongue. Now, these are essentially ripped straight from the Hippocratic corpus, aren't they?
They are, yeah.
Yeah.
The physicians in ancient Greece associated with Hippocrates, they were writing clinical observations using these exact terms way back in the 5th and 4th centuries BCE.
So it was like the gold standard of medical knowledge back then.
Absolutely the gold standard. To practice serious medicine in the ancient world, you had to be reading and writing in Greek.
But then, obviously, the Roman Empire enters the chat.
As they do.
Right. And suddenly we get the Latin side of the equation thrown in. We get oro from the Latin os, or orus for mouth, and linguo from lingua for tongue. So if the Greeks already had this perfectly functional, widely accepted dictionary, how did Latin crash the party? Why do we have double the vocabulary for the exact same body parts?
Well, that falls largely on a Roman writer named Celsus in the 1st century CE. He took on this truly monumental task of writing De Medicina, trying to bring all that sophisticated Greek clinical knowledge to a Roman audience.
Okay.
But Celsus had a really practical problem. He was writing in Latin, so he naturally translated the physical anatomical structures into the everyday Latin his readers actually spoke.
Right, so an everyday Roman reader knows the mouth is the os and the tongue is the lingua.
Exactly. But when it came to the complex diseases, the inflammations, the surgical procedures, Latin simply didn't have the vocabulary for that.
Oh, I see.
So Celsus just kept the Greek roots for the pathology. And he inadvertently created this permanent hybridized system where we use one language for the body part and a completely different language for what goes wrong with it.
That is so funny. It's almost like the hardware of a computer versus the software.
Oh, that's a great way to look at it.
Like the Latin terms describe the physical hardware, so the structures themselves, like the oral cavity or the lingual frenulum.
Yeah.
But the Greek terms describe the software bugs.
Yes. The diseases, the inflammation, the procedures happening to that hardware like stomatitis or glossectomy.
The hardware-software split. That makes so much sense.
And that framing maps perfectly onto how the medical establishment eventually tried to, clean up this mess. In 1895, European anatomists got together and created the Basal Nomina Anatomica.
Okay, so trying to standardize things.
Exactly. They formally locked in Latin as the official language of the physical structures. But clinical medicine, the people actually treating the diseases, they fiercely protected their Greek-derived pathology terms.
Which creates a permanent fracture in the profession.
Right.
And actually, if you travel, you can see how this linguistic fracture turned into an institutional one. Like in the United States, we have dentistry, which operates in its own separate sphere from medicine, right? Separate dental schools and everything.
Yeah.
But in France and heavily in Russia, stomatology is a completely distinct medical specialty.
Yes, it is.
A stomatologist is a licensed medical doctor specializing in the oral cavity.
It's just fascinating how a Greek root word essentially became a completely siloed medical identity.
It really highlights how these aren't just dead prefixes and suffixes.
Hmm.
But speaking of prefixes and suffixes, this hardware-software split does give us a highly modular system for building clinical terms. You take your root like stomato and you just attach a modifier.
Right, so we take stomato and attach meitis, and boom, we've got stomatitis.
But I want to push on how practical this modular system really is.
Yeah.
Because when you look at a term in the literature like aphthous stomatitis,
Oh,
it sounds like this highly exotic flesh-eating pathogen. But clinically, what are we actually talking about here?
we are literally talking about the common canker sore.
A canker sore.
Just a standard, shallow mucosal ulcer. The terminology sounds super intimidating, but stomatitis just tells us the tissue lining the mouth is inflamed. The aphthous part describes a specific presentation, so a small, painful, benign ulceration.
Wow.
Yeah, by snapping those words together, a doctor instantly differentiates a canker sore from, say, a viral herpes lesion or oral thrush, purely through the structural description.
Okay, so we've snapped together these basic pieces for the mouth itself. But how well does this modular naming convention hold up when we map it onto something deeply complex, like the brain's actual wiring? Because the cranial nerves seem like a place where this system would just hit a wall.
You'd think so, but it actually works beautifully for the nervous system, particularly for the nerves controlling the tongue. Take cranial nerve 12, the hypoglossal nerve.
Hypoglossal. So
No.
hypo meaning under, glosso meaning tongue.
Right.
So literally the nerve routing under the tongue.
Yep. And that precise anatomical naming is crucial because of how the nerve functions mechanically. The hypoglossal nerve provides the motor control to the muscles of the tongue, most importantly, the genioglossus muscle, which is responsible for sticking the tongue out.
And doctors test this all the time, right? In a standard stroke exam, the physician asks the patient to stick their tongue straight out. I've always wondered, what is the actual physical mechanism they're looking for when the tongue deviates to one side?
It's actually a brilliant question of physics. When you stick your tongue out, both the left and right genioglossus muscles push forward simultaneously.
So they keep the tongue centered.
Exactly. But if a patient has suffered a stroke or a lesion that damages the right hypoglossal nerve, the right side of the tongue becomes weak or completely flaccid, but the left side is still firing perfectly.
Oh, so the left muscle just pushes unopposed.
You got it. It drives the tongue over toward the right side, so the tongue physically points toward the side of the damaged nerve.
That is incredible. The healthy side overpowers the paralyzed side and just shoves it off center.
Exactly.
That makes so much sense. What about cranial nerve 9, the glossopharyngeal nerve?
Again, the name just maps the geography. Glosso for the back of the tongue and pharyngo for the throat. It carries taste sensation and triggers the gag reflex.
Okay.
But when this nerve malfunctions, it results in a condition called glossopharyngeal neuralgia.
And the literature describes this as one of the most excruciating pain disorders known to medicine.
Yeah.
Why is it so severe? Like, what's happening structurally?
Well, in many cases, a blood vessel at the base of the brain is physically pressing against the root of that nerve. Over time, that constant pulsing wears away the myelin sheath, which is the protective insulation around the nerve.
Oh, wow. So without that
The
insulation,
nerve just starts misfiring wildly, like a stripped electrical wire. So everyday actions, swallowing, chewing, or even just talking, trigger this massive electric shock-like pain signal straight from the throat and tongue right into the brain.
man, that really grounds the vocabulary. You're not just memorizing the word glossopharyngeal, you're identifying the exact circuit board that's shorting out.
Exactly.
And just to zoom out on this anatomical neighborhood for a second, the mouth obviously doesn't operate in a vacuum. We have gingival for the gums, dento for teeth, palato for the palate. But the one that really stands out clinically is bucco for the cheek.
Oh, absolutely. Bucco is vital in pharmacology because of the buccal medication route, where a drug is placed between the gums and the inner cheek lining.
Right. But wait, if the whole mouth is essentially one giant cavity, why do pharmacologists make such a strict distinction between buccal delivery in the cheek and sublingual delivery under the tongue? Isn't it all just absorbing into the exact same mucous membrane?
You'd think, but it really comes down to blood flow and absorption rates. Both routes bypass the digestive system and the liver, which is called avoiding first-pass metabolism.
Right, because if you swallow a pill, the liver filters out a lot of the drug before it even reaches your bloodstream.
Exactly. The mouth bypasses that entirely. But the sublingual area under the tongue has a massively dense, highly permeable capillary bed.
Okay.
So drugs dissolve and hit the systemic bloodstream almost instantly. Think like Nitroglycerin for a heart attack.
So it's an emergency bypass.
Yes. The buccal mucosa inside the cheek, however, is much thicker and less permeable. So doctors use the buccal route when they want a sustained, slower release of a medication over time, like certain hormone therapies or pain management lozenges. The specific anatomical route dictates the pharmacokinetics.
That makes perfect sense. But let's shift gears a little bit, because if we're borrowing heavily from these dead classical languages, the phonetics must create an absolute mess.
Oh, a total mess.
Right, like this modular system seems great on paper, but language plays tricks on us. What is the biggest trap doctors and students fall into with these roots?
Honestly, the most notorious false friend in medical terminology is confusing stomato with the stomach.
Because in English, they're near homophones. Stomato, stomach.
Yeah.
It feels like a completely natural linguistic bridge.
It feels natural, but it is entirely incorrect. They have completely unrelated Greek origins. Stomato, as we know, is the mouth. The stomach, the muscular organ churning food in your abdomen, comes from the Greek gaster. That's your gastritis, your gastric bypass, your gastroenterology.
Wow. So if a clinician is looking at a chart, they have to mentally decouple the sound of the word stomach from the root stomato. If they mix those up, they are treating the completely wrong end of the digestive tract.
And the phonetic traps really don't end there. Think about spoken medical orders on a chaotic hospital floor. We have oral, meaning mouth, from the Latin os, and we have oral, meaning ear, from the Latin orus.
Oh, no. So in a noisy ward, a doctor shouting, "Give them these drops orally," sounds exactly the same as "give them these drops orally."
Which is exactly how you end up with eardrops in a patient's mouth or oral antibiotics dropped into an ear canal.
Yikes.
Yeah, it is a heavily documented source of clinical error. To mitigate this, hospitals heavily rely on written charting with specific abbreviations. For oral medications, they use PO, which stands for per os, the Latin for by mouth. It pulls the phonetic ambiguity completely out of the equation.
That's smart. And since we're on the Latin word os, doesn't Latin have a secondary translation for that exact spelling that causes even more chaos?
Yes, it is a bizarre classical coincidence. Os, orus, is the noun for mouth. But osis, is the noun for bone.
Oh, wow.
They belong to completely different Latin declension groups, but in their nominative singular form, they are spelled identically. O-I-S.
So a researcher reading historical medical texts, or even a student today looking at an anatomical prefix, has to rely entirely on context to know if they're looking at the mouth like an orifice or a bone, like in osteology.
Context is absolutely everything, especially when you consider how the definitions of these words drift and mutate over time. The scope of a root word rarely stays frozen.
Right, let's talk about that drift, because the word stoma has gone on an incredible journey. We've established it means the anatomical mouth. But if you walk onto a surgical floor today and hear a surgeon talking about a stoma, they might be pointing to a patient's abdomen or their neck.
Yeah, in modern surgery, a stoma refers to any artificially created opening in the body. If a patient has part of their intestine removed, the surgeon might create a colostomy or an ileostomy, essentially bringing the healthy bowel through the abdominal wall so waste can exit. That opening on the abdomen is called a stoma.
Right, or a tracheostomy, a breathing hole in the neck, that's also a stoma. It's conceptually really similar to how we use the word desktop in everyday life.
Right.
Like 50 years ago, your desktop was a physical piece of oak furniture. But when computers arrived, we needed a word for the primary digital workspace. We didn't invent a new word, we just broadened the scope of desktop to fit the new technology.
That is a phenomenal analogy. The surgical community needed a word for these new artificially created openings, and they just, hijacked the Greek word for mouth.
Makes sense.
Though, to be fair to the modern surgeons, the ancient Greeks were actually quite flexible with the word stoma. They used it to describe the mouth on your face, but also the mouth of a river, the opening of a wound, or even the cervix. Modern surgery just returned the word to its original metaphorical flexibility.
That is so interesting. Well, that brings us to our final segment. We've talked about the history, the phonetics, and the scope drift. But these root words aren't just trivia. They are at the dead center of active and, frankly, pretty controversial clinical decisions today. Let's look at the tongue specifically.
The tongue is uniquely high stakes. It's not just a muscle for speech. It is a diagnostic dashboard for your systemic health.
Okay, let's start with a major debate in pediatrics right now. Ankyloglossia. So, ankylo meaning fused or bent, and glosso for tongue. Basically, a restricted tongue, commonly known as a tongue tie.
Anatomically, this happens when the lingual frenulum, that small band of tissue connecting the underside of the tongue to the floor of the mouth, is unusually short, thick, or tight. It physically tethers the tongue, restricting its range of motion.
Okay.
The intervention for this is a frenotomy, where a surgeon snips or lasers the tissue to release it.
Now, the literature we reviewed shows that the rates of frenotomies in infants have absolutely skyrocketed over the last 20 years, specifically tied to breastfeeding difficulties. Now, we aren't taking a side here, but what exactly is the clinical debate surrounding this massive explosion in procedures?
It's fiercely debated among pediatricians, lactation consultants, and ENT surgeons. One camp points out that breastfeeding requires the infant's tongue to elevate and cup the breast to create a vacuum. If the tongue is tethered, the infant can't latch.
Which leads to failure to thrive for the baby and obviously agonizing pain for the mother.
Exactly. So they argue the spike in surgeries is a good thing, that we are finally diagnosing and treating a mechanical problem that was historically just ignored.
But the other camp looks at that skyrocketing graph and sees over-medicalization.
Yes, they do. They argue that normal variations in anatomy are being pathologized. They worry that exhausted, struggling new parents are being pushed toward unnecessary laser surgeries on their infants when the real issue might just be, positioning, milk supply, or a need for basic lactation support.
Wow.
It is a live, ongoing debate about where the threshold for surgical intervention truly lies.
It just proves that ankyloglossia isn't a dead textbook term. It's a very dynamic clinical flashpoint.
Yeah.
But you also called the tongue a diagnostic dashboard earlier. What kind of systemic clues does it give a physician?
Well, a classic example is glossitis, specifically when a doctor observes a perfectly smooth, beefy red tongue.
Okay, why does it look like that? Like, what is the mechanism making it smooth and red?
Your tongue is normally covered in tiny bumps called funiform papillae. The cells making up those bumps have an incredibly fast turnover rate. To constantly regenerate those cells, your body requires robust DNA synthesis, which relies really heavily on vitamin B12 and folate.
Okay.
If a patient is profoundly deficient in B12, their body literally cannot synthesize DNA fast enough to replace those tongue cells.
Oh, so the papillae just slow off and they don't grow back.
Exactly. The tongue becomes bald and atrophic. The beefy red color comes from the underlying blood vessels becoming highly visible without that protective cellular layer on top.
Oh, wow.
So a physician sees a smooth red tongue and instantly knows they need to draw blood for a B12 or iron deficiency.
That is completely fascinating. What about macroglossia? An enlarged tongue?
That's a critical red flag. An abnormally large tongue isn't typically just an isolated issue. It usually points to systemic conditions. For example, in systemic amyloidosis, abnormal proteins circulating in the blood physically deposit themselves into the muscle tissue of the tongue, expanding its mass.
Wow.
It also presents in congenital hypothyroidism and Down syndrome.
And on the day-to-day quality of life side, we have xerostomia. So, dry mouth.
Yeah, this is a massive and honestly often dismissed burden, particularly for older adults. It is largely driven by medications.
How do medications cause dry mouth?
Well, many common drugs, antihistamines, antidepressants, blood pressure medications, they have anticholinergic properties, meaning they block the neurotransmitter acetylcholine, which is the signal the parasympathetic nervous system uses to tell your salivary glands to produce saliva.
So without that signal, the glands just shut down.
They do, and it alters taste, accelerates severe tooth decay, and makes swallowing food incredibly difficult.
Man. Finally, we have to touch on the oncology ward, oral mucositis.
Yeah, this is one of the most punishing side effects in cancer treatment. Chemotherapy drugs are designed to hunt down and destroy rapidly dividing cells because, well, that is what a tumor is.
Right.
But the drugs aren't smart enough to differentiate a cancer cell from the healthy cells lining your mouth.
And you mentioned earlier that the mucosal lining of the mouth replaces itself incredibly fast.
It turns over every 3 to 5 days. So when chemotherapy halts that rapid cellular division, the mucosal lining physically breaks down. Patients develop widespread, agonizing ulcerations throughout the stomatostructures.
That sounds awful.
It can become so severe that patients literally cannot eat, requiring feeding tubes, or it forces oncologists to pause life-saving cancer treatments just to let the mouth heal.
Wow. It really pulls everything we've talked about into sharp focus. These root words carry immense weight. I mean, we've journeyed from the scrolls of Hippocrates and the translation dilemmas of Celsus to the complex wiring of the cranial nerves, all the way to modern pediatric debates and the front lines of oncology.
Yeah, and the through line here is that oro, stomato, and glosso aren't just linguistic trivia to be memorized for a multiple choice exam. They are the actual mechanics of survival, diagnosis, and treatment. They are the foundational code that allows healthcare to function globally.
Perfectly said. So as we wrap up this deep dive into the gateway of the digestive tract, I really want to leave you with a final thought to mull over. We've seen how medical language isn't pristine, right? It's messy, and it evolves constantly. The word stoma expanded over a single century, from meaning just the mouth on your face to meaning an artificial surgical opening on your abdomen. So think about the cutting-edge medical terms being coined in hospitals right now today, words surrounding mRNA or neural implants or CRISPR. What common medical terms that we use with absolute certainty right now might stretch, drift, and mean something completely unimaginable to a patient 100 years from now?
It's an essential question. The language of medicine is never truly finished, it just adapts to the next era of discovery.
Exactly. Keep asking questions, keep unpacking the words around you, and we'll see you on the next deep dive.